Good evening to all of you. I'm extremely thankful to Lal Uday and team for inviting me as a guest speaker on this, a happy con. I'm sorry, due to multiple commitments, I could not be directly present since this recorded video is being sent. The title of today's topic is Thyroid Dysfunction and Cardiovascular Diseases. I'll just try to conclude by saying that thyrocardiovascular medicine is an emerging subspecialty. I think this communication will definitely justify that statement. We'll see that what it is. And this is the content or the framework. We just talked something about thyroid dysfunctions and various clinical entities of low thyroid and high thyroid and its relations to cardiovascular problems. And we will again conclude. All of us know thyroid is endocrine gland, which is situated in the neck, and it is controlled by, hypothalamus, and it can be a over-functioning gland or under-functioning gland. Based on that, the clinical features will vary. Both hyperthyroidism and hypothyroidism can produce changes in myocardial contractions, myocardial oxygen consumption, cardiac output, blood pressure, and systemic vascular resistance. The incidence in general globally is around 9 to 15% cardiovascular diseases in thyroid, and females have a larger, segment than the males. And in India, the hypothyroidism has been reported to be about 10.95% average, and there is a higher proportion in females around 15.86%. In male about 5.02. Here it is around 16, here around 5. Subclinical hypothyroidism was also observed in 8% of the population as reported by Dr. A.G. Unnikrishnan. See, the thyroid, dysfunction, you can have a low developing or rather low level hypothyroidism, which can be three types: primary, secondary, tertiary. Primary is due to a failure of the thyroid gland, maybe autoimmune or due to some infection or removal or malignancy, whatever it is. And here the T3, T4 are low and TSH is high. And secondary is due to control failure, wherein the TSH is fairly normal and T3, T4 can be reduced. And there is a tertiary one wherein the hypothalamic thyrotrophin releasing hormone is deficient, and though it is rare, but that entity is there. And clinically, you can have a clinical hypothyroidism. That is, the blood levels may be abnormal, but not to the characteristic level. But the clinical feature is classical. There is an obesity, thick skin, and mental slowing, depression, constipation, dry skin. All are there. You will have to treat it as clinical hypothyroidism. Overt hypothyroidism is classical. The TSI levels are raised, and T4 and T3 are low. Secondary, we already discussed, and tertiary also we already discussed. Now coming to a few important types, subtypes. One is a subclinical hypothyroidism. The patient has, thyroid hormone levels within their reference, but the TSH concentrations are not that much raised. For example, a T3, T4 can be normal. TSH alone can be raised, can be of two types. One is just above 4 up to 10, it is grade 1. And it is, grade 2 means about 10. It's a subclinical hypothyroid. Why it is important, we will see that. There is another entity called a euthyroid 6 syndrome. Thyroid is normal. Non-thyroidal illness. In a non-thyroid illness, without pre-existing hypothalamic pituitary or thyroid gland dysfunction. This is also called as a low T3 syndrome. The triiodothyronine is low. There is an entity called as a reverse T3. And this liver T3 is elevated. If you see here, after TSH, you have T3 formed, which also forms T3. T4 is formed, it goes to T3. Sometimes from this T3, T4, the iodine can be removed and it goes to an inactive form called as RT3, a reverse T3. This goes on rising up, but the thyroid, since this is inactive, you have subclinical hypothyroidism or low T3 syndrome. There also cardiac events are more common. That is why we are concerned about it. Coming to hyperthyroidism, we are all familiar with thyrotoxicosis, and there is an entity called subclinical hyperthyroidism also. That is T3, low TSH, but the free T3 and T4 are fairly within normal limit. We call it subclinical. And overt is wherein T3, T4 are high and TSH is very much low. These are all the clinical types. And the clinical presentation of the thyrocardiac disease. In hyperthyroidism, how it presents, in hypothyroidism, how it presents, we'll see. In hyperthyroidism, all of us know it is a tachyarrhythmic syndrome. Patient has a palpitation, exercise intolerance, exertional dyspnea, angina, and clinically when you examine on the sign side, sinus tachycardia, systemic hypertension, atrial fibrillation, and then a hyperdynamic precardium, jumping, cardiac hypertrophy, and a high output cardiac failure. In hypothyroidism, there is a fatigue, exercise intolerance, palpitation. You have a diastolic hypertension due to decreased arterial elasticity, and bradycardia is the hallmark, QT prolongation, torsades point is periorbital edema, pericardial effusion, again very classical, and a heart failure, systolic or diastolic, or both cardiomyopathy. These are the clinical presentations of the thyrocardiac disease. This is again another entity, thyrocardiac disease. Now, to summarize the cardiovascular risks associated with hypothyroidism, there is an impaired cardiac contractility and diastolic function. There is an increased systemic vascular resistance, decreased endothelial-derived relaxation factor, and increased cholesterol, C-reactive protein, and homocysteine. Thyroid hormone is anti-atherosclerotic, decreases vascular disease, and decreases cholesterol. In its deficiency, all the three factors are affected. Heart disease and T3. There is a study which says 30% of the patients with heart failure have low T3. We never do that. Our cardiologists are not keen to evaluate it. They are keen to only, correct the cardiac failure and save their life. But when you do a scientific study, 30% of them have, cardiac failures have low T3. The decrease in serum T3 is proportional to the severity of the heart disease. When the heart failure is very severe, T3 is very low. It is very mild, T3 is also low. And cardiomyocytes has no appreciable deiodinase activity. Therefore, it relies only on the plasma T3 levels. And reduced T3 is a strong predictor of all-cause mortality and cardiovascular mortality. And supplementation with physiological T3, it improves the cardiac function. Low T3 states are being evaluated for heart failure now. Now, how the T3 and T4 act on the cardiovascular hemodynamics? First is there is a tissue level, and you go for the vascular resistance. In hyperthyroidism, it is fairly normal or low. In hypothyroidism, it is very much increased, and it leads to a diastolic blood pressure and afterload increase and sorry, cardiac chronotrophy, ionotrophy are increased and cardiac output is increased. And similarly, there can be an increase in the pulmonary pressure. There are a lot of studies which says that the cause for hyperthyroidism and pulmonary hypertension can be autoimmune. We'll see that. And the second is its effect on the RAS system, which changes the preload and can go for a cardiac failure. This is the mechanism. One is smooth muscle relaxation is not there. Therefore, the vascular resistance increases. They act on the RAS system. Both promote a cardiac failure. There is a direct effect of thyroid hormone on the heart. It is regulated by cardiac gene expressions. And T3 has both genomic and non-genomic effects on the cardiac myocyte. We'll see that. See, the T3 has a genomic and non-genomic effect on the on the heart. The genomic directly goes to the cells and decreases the fibrosis and enhances calcium, transit. Non-genomic, it goes to the vessel wall and it goes to a RAS system and it, enhances the myocardial contractility. Genomic and non-genomic activity. The genomics of T3, there are 6 genes which are positively regulating the cardiac function in presence of T3, and negatively regulating 6 are there. And they are now in future, we may be asked to evaluate these genomes to say that this heart failure is secondary to, T3 deficiency. The effect of T3 on cardiovascular hemodynamics, it decreases the systemic vascular resistance and resting heart rate, left ventricular contractility, and blood volume. And thyroid hormone causes decreased resistance in the peripheral arterial system and activates the RAS, which we have seen already. It increases the erythropoietin synthesis. In hyperthyroidism, these combined effects increase the cardiac output to up to 300%, high output cardiac failure. In hypothyroidism, output is reduced to up to 50%. T3 and T4 are important regulators of cardiac function and cardiovascular hemodynamics. This is the thyroid hormone effects on cardiovascular system in short. This is on the blood vessels. It relaxes the smooth muscle and reduces the BP. When hypothyroidism, it increases, and then there is an endothelial, risk factor and platelet aggregation, and then this lipid abnormalities goes to vascular thrombus. Directly acts on the myocardium and the coronary arteries. It promotes a atherosclerosis and a coronary artery disease. There are some extra sites of TSH action. One is an adipocyte, another is vascular smooth muscle, which we saw. Endothelial cells also we have seen. It can act on the monocytes and platelets and promote inflammation and thrombosis and results in cardiovascular disease. On the RAS system, when thyroid hormone acts on the RAS system in hypothyroidism, all the 4 are reduced. Plasma renin activity, angiotensin, aldosterone, sodium reabsorption. In hyperthyroidism, all are increased. Thereby, the systemic vascular resistance and afterload are altered. Thyroid hormone effects on the blood pressure regulation. As we said, that thyroid controls the vascular smooth muscle. It is making it to relax. When it is deficient, the vascular smooth muscle does not relax and the SVR goes up. Not only that, on this endothelial dysfunction is also there. Thereby, it leads to blood pressure controlled deficiency and vascular accident. Thyroid functions and hypertension. Overt and subclinical hyper and hypothyroidism can both lead to hypertension. And the high prevalence of diastolic hypertension is there in hypothyroidism. The gene mutation have a role in it. After levothyroxine, systolic blood pressure is very much under control. This is the effect of thyroid on hypertension. Hypothyroid directly acts on the vessel wall, increases the stiffness and resistance increase, and it acts on the endothelium and causes an endothelial dysfunction and low-grade inflammation, and combined with hypercholesterolemia and causes a hypertension. And thyroid disease and pulmonary hypertension, as I made a small mention, both primarily, the pulmonary hypertension has been associated with the thyroid, dysfunction, mostly hyperthyroid state. And there are some evidences that autoimmune disease may play a role in both hypo and hyperthyroidism, which are linked to primary pulmonary hypertension. Therefore, thyroid disease must be considered in the differential diagnosis of primary pulmonary hypertension. Before saying PPH, we need to evaluate for thyroid dysfunction, hypo or hyper. and thyroid hormone and lipids. And overt hypothyroidism causes hypercholesterolemia. I mean, this apolipoprotein B and LDL are also elevated. And lipid profile changes are seen not only in hypothyroidism clinical, but subclinical hypothyroidism also. There is an increase in the cholesterol synthesis and cellular uptake. Thyroid hormone replacement reduces to euthyroidism. When thyroid hormone replacement is given, euthyroidism is restored and the cholesterol levels are also brought down. This is what the effect of thyroid and lipid metabolism. The LDL receptors are increased, LDL receptor activity and the LDL clearance all decrease, homocysteine is increased, and you have cholesterol, LDL, apolipoprotein B, all are increased. That is why there is a negative, effect on the vascular, fat deposits. Arrhythmias in thyroid function. Hyperthyroidism, all of us know, it's a rate related phenomenon. And hypothyroidism always has a bradycardia. Q2 interval is often prolonged and varying degrees of blocks. See, hyperthyroidism is associated with the tachyarrhythmia. Hypothyroidism is associated with the bradyarrhythmia. And various types of changes like bradycardia, RBB, flat or inverted TVA, QRS prolongation, QT, torsade dyspointes, or AF. These are the various types of dysrhythmia we see in cases of thyroid dysfunction. And thyroid and hypothyroidism and pericardial effusion is a time-honored observation in clinical medicine. Whenever there is a cardiomegaly in thyroid, we don't say that it is due to a cardiomyopathy, maybe due to a pericardial effusion, which is an effusive type, not a transudate. It is due to cholesterol. It will be xanthochromic. There is an increased permeability of the epicardial vessels and decreased clearance. Therefore, fluid in the pericardial space and presence as a pericardial effusion. Echocardiography clearly differentiates the amount of fluid, its location. If need be, we may have to remove it. And thyroid dysfunction and atherosclerosis. Thyroid hormone has direct anti-atherosclerotic effects, as we have seen. Thyroid hormone inhibits atherogenesis, and there is a deficiency, there is hyperhomocysteinemia, increased C-reactive protein that promotes an atherosclerosis. And atherogenic effect of hypothyroidism, here there is these are the traditional factors. Cholesterol, CRP are raised. Here the nitric oxide is reduced, angiotensin receptors increase, and acceleration of atherosclerosis happens. And heart failure and thyroid dysfunction. There are multiple studies. There are about 13% of class 1, failure, and 30% of New York Heart Association class 3 and 4. And it is not only seen in overt thyroid, in hypothyroidism, but also seen in subclinical and low T3 syndromes also. Patients with hyperthyroidism will also have signs of heart failure, but it is usually a high output heart failure. Pre-existing heart disease, hypertension, heart disease may precipitate a cardiac failure. There is increased risk of mitral valve prolapse and atrial fibrillation. Therefore, then, ladies and gentlemen, thyroid dysfunction is a modifier risk factor in patients who are at risk of heart failure. In people who are at the risk of heart failure, if you correct the thyroid deficiency or thyroid excess, the heart failure incidence can be brought down. These are the types of heart failure. In hyperthyroidism, you have a heart failure with preserved ejection fraction, increased cardiac output, and there can be a low output heart failure also when the preload is increased, whereas in hypothyroidism, it is always a reduced ejection fraction. We need to be very conscious of it, and the level of the EF and the level of T3 directly correlate. The low EF and low T3, the outcome is bad. These are the studies which have been said. This is the mechanism of heart failure in thyroid dysfunction. And there are, as we already said, peripheral resistance is increased, contractility is increased. This is for hyperthyroidism. There is an atrial fibrillation, systolic and diastolic dysfunction, and heart failure, cardiac output is increased. In hypothyroidism, the routine factors are also acting, and there can be an amiodarone therapy which can also precipitate a systolic and diastolic dysfunction and a heart failure with reduced ejection fraction. That is more common in hypothyroidism as well as in low T3 syndrome. Management of heart failure in patients with increased thyroid hormone, you have to stabilize the cardiac failure, inhibit the thyroid hormones by using anti-thyroid drugs, and beta blockers and usual heart failure drugs are useful. In hypothyroidism with heart failure, you do a stabilization, thyroid hormone replacement, and usual heart failure drugs have to be used. The replacement, the one word about the thyroid hormone replacement therapy in people with heart failure is always you'll have to, the patient will respond well to heart failure, but you'll have to start with a low dose, 12.5 or even 25 microgram. Otherwise, angina will be precipitated. There is a remodeling effect of thyroid hormone, which we call it as a cardio protective effect. Euthyroid state is preferred, start low and step up slowly. These are certain clinical clues. When there is an atrial fibrillation, always try to check for thyroid testing and then start on beta blockers to control the ventricular rate. When there is a heart failure, always do a T3, T4, TSH checking and cardiomyopathy. Amiodarone, it's a double-edged weapon. Therefore, amiodarone, when you use it, it has to be monitored with TSH levels. In subclinical hyperthyroidism also, and the TSH level is low, persistently 0.1, you will have to treat hyperthyroidism. When in a cardiac disease, consider treatment if the TSH is persistently low between 0.1, sorry, 0.1 to zero point 0.4. With a known coronary artery disease, as we said earlier, start on levothyroxine, low dose and slowly step up. In subclinical hypothyroidism also, when the TSH is above 7, kindly start with levothyroxine. And there is a two-way relationship. See, hypothyroidism, creates a heart disease. Heart disease also affects the thyroid by causing a euthyroid 6 syndrome. Therefore, you will have to screen, both ways. Heart patients screen for thyroid and thyroid patient screen for a heart disease. These are all the clinical situations wherein you will have to look for thyrovigilance. You will have to check for thyroid function test. Any cardiovascular disease, any hypertension, dysrhythmia, tachycardia, heart failure, dyslipidemia, pericardial effusion, obesity, weight loss, chronic kidney disease, pregnancy with dysfunctional uterine bleeding. Always, I mean, it is not restricted to medicine and cardiology. It is restricted to every disease, every system of internal medicine. Therefore, we should be very clear when all we need to, look for, I mean, thyroid deficiency or excess. Subclinical thyroid function. As I said, subclinically it could be a hyperthyroidism or hypothyroidism. In subclinical hyperthyroidism also, dysrhythmias and heart failures are very common. And in hypothyroidism, and blood pressure, tachyarrhythmias, heart failure are very common. Therefore, even subclinical thyroid dysfunctions causes increased cardiovascular morbidity and mortality. One word of hypothyroidism and hyperthyroidism in elderly. In elderly patients, cardiovascular disease are more common. The TSH levels are little on the higher level, which we don't take it as hyperthyroidism. Whereas hypothyroidism, we need to take care. And the dose, as we said, has to be very low and it needs further evaluation. A word of caution is about TSH levels. If it is on the hyperthyroid level also, let us wait because it can be little higher in senior citizens. Now, ladies and gentlemen, these are the following statements we make. Thyroid is intricately related to the cardiovascular system, a common embryonic origin. T3 and T4 are important regulators of cardiac function and cardiovascular hemodynamics. Heart is sensitive even to small changes of thyroid hormone level. Thyroid hormone produces changes in the vascular reactivity, endothelial function, arterial stiffness, and endothelial dysfunction. And the thyroid dysfunction causes CVD or worsens the existing disease. Now, these are the actionables out of this communication. I mean, when we were all undergraduate students in 60s, we used to be said, our teachers know syphilis, you will know medicine. And Professor Sam G.P. Moses, uh, after 1970s, started telling, you know diabetes, you know medicine. In 2020, probably the statement that I will make is, you know thyroid, you know medicine. The above statements will definitely justify this. And cardiovascular medicine is emerging subspecialty in developed nations. Soon will happen in our own country too. I have seen many places only TSH is done. When thyroid function test is asked, only TSH is done. No. I mean, we like to ask for a total T3, T4, free T3, free T4, and TSH, not TSH alone. And initiate low dose of thyroid replacement and up titrate. Low T3 syndrome is important. Subclinical hypothyroidism is equally important as pre-diabetes. I mean, a subclinical hypothyroidism, we can say it's a pre-hypothyroidism. Like the pre-diabetic state, now we are concentrating because the risk factors and complications are same. Ladies and gentlemen, now I have just conveyed you, I mean, at what stage a cardiovascular system can be deranged in both hyperthyroidism and hypothyroidism. There are a few different types of it, like subclinical, therefore, and low T3. We do a total thyroid evaluation, and we need to evaluate for thyroid function in every cardiovascular system disease. Thank you very much. Thank you very much.